All right, that's enough for me. It is my sincere pleasure to welcome Dr. Kathryn Fay. She is our second-year fellow in complex family planning. She grew up on the East Coast and completed her undergraduate work on women and gender studies at Dartmouth College. She worked as a domestic and sexual violence advocate for several years before moving to the Midwest for medical school and residency in obstetrics and gynecology at Northwestern University. Her research interests are focused on the intersection of violence, autonomy, and reproductive justice with a special interest in reproductive coercion. Dr. Fay, take it away.
Thank you so much. Let me start with some screen sharing. All right, everyone can see okay? Let me take that as a yes. Perfect. Okay, and everyone can hear me okay? Yes and yes, perfect, awesome. So in the interest of time, I ran a little bit over last time, so I'm going to go speedily through this first part here so we have plenty of time for questions and discussion at the end. If I miss something in the chat or if something comes up as we go along, again, please interrupt me. So we're going to be talking about a particular facet of intimate partner violence today, reproductive coercion. And I think in recognition of the pervasiveness of intimate partner violence and sexual violence, I want to note that there will be some content today about tactics and effects of intimate partner violence, including quotations from survivors that can be upsetting to some. In fact, I chose this topic not only because reproductive autonomy is an academic interest of mine, but also because consent and choice have affected everyone listening to some degree through our patients or in our own lives. I do not have any disclosures. Our objectives today will be to affirm that violence is a health phenomenon, to review the current terminology and theory of IPV or intimate partner violence, to define reproductive coercion and its recognition in the clinical setting, and to highlight some interventions for reproductive coercion that are routine in reproductive and sexual health care. So first, I think before I spend a lot of time talking about IPV and RC or reproductive coercion, the argument that violence is a part of healthcare and its recognition in the clinical setting is a critical part of optimized care, it needs to be made. So I want to address that briefly very briefly in the next few slides. Starting with noting that violence is a major contributor to premature death, disability, and injury, particularly among already marginalized or disadvantaged populations. And in recognizing the burden of violence on health, we've really sparked a shift in focus from reactionary punitive measures to preventing violence with policies based on scientific evidence. So this is the idea that violence is not an inevitable part of our lives, but rather a problem that can be studied, understood, and avoided. In the United States, the drive to conceive of violence differently was thought to be inspired by the rise in violent crime after World War II, shown here from some FBI data, peaking in the late 70s and 80s with this historical approach of apprehension, incarceration, without any really appreciable difference in violent crime. These data on violent crime also show that over time there are different rates of violent crime, but there's also wide variation in homicide rates among persons of similar demographics and similar nations, which really supports this notion that violence is not a consequence of living in an imperfect society, but rather it's something that can be prevented. This is also, I think, supported by changes in rates of violent crime following specific interventions like firearm restrictions in Washington, D.C., or school communication and conflict resolution programs, the following in implementation in specific neighborhoods that I'll talk about in the next slide. These are data from the most recent kind of FBI analysis of the top 48 largest cities. We're based in Salt Lake City, which I think is the 51st largest city, so it's not on here. But this is showing variations again over time in geography and violent crime. I do think it's important to know what's happening in our own communities. So I looked up Utah, and here we can see, well, Utah has much lower rates of violent crime in general compared to the national rates. There are higher rates of sexual violence, of rape, and this is a change in the definition that was used in collecting these data here, but you can see that Utah has higher rates. And I think there are complex theories behind why this trend occurs. And data collection behind the study of violence is increasingly sophisticated because of the growing legitimacy and investment in a public health model approach to violence. So what this means is that we now have these surveillance tools for violence to facilitate risk factor identification and development of interventions, which have been used successfully with infectious diseases, smoking, and car safety with great success. Briefly, I think it's helpful to see the progress that's been made over time with this idea of violence as a form of an important part of healthcare, but also the relative nascency of some of these efforts. I'm going to speed through this relatively quickly, but you can find this on the CDC website. It has a really awesome interactive website that goes through this history. But basically in 1979, that was the first time in the Surgeon General's report that violence was identified as one of 15 priority areas for the nation. And that's when really there was kind of one of the first assertions that violence can be prevented and should not be ignored in an effort to improve the nation's health. This was followed by some establishment of different divisions within the CDC, inclusion in Healthy People 2000, and kind of naming this as a top priority area of health for the nation. And then also the implementation of new surveillance systems, including identifying violence as a major contributor to leading causes of death and disability, particularly in a youth population. 1994 was a big year in that Congress passed the VAWA, Violence Against Women Act, which provided specialized funding in recognizing and studying and also prosecuting violence against women. And also when there was this kind of early conception of a national violence against women survey. In 2002, the CDC received appropriation to establish the National Violent Death Reporting System. So this is really the first time that there's state-based surveillance system to link data from multiple sources to enhance violence prevention strategies. In 2010, so a mere 10 years ago, the CDC implemented a new surveillance system, the National Intimate Partner and Sexual Violence Survey, which will revisit data from that 2010 report shortly. And so this is really the first concerted national effort to collect data on what I'll argue is an epidemic problem. And then 2019, so just last year, the first findings from the CDC's comprehensive teen dating violence prevention program were released. And that showed that this is a program that effectively reduces teen dating violence, which is really exciting. Speeding right through, we're going to talk about intimate partner violence. So while we could spend, I think, a semester talking about violence as part of healthcare and how violence is preventable, I'm hoping that by introducing these concepts, we can use them as a framework in approaching intimate partner violence for the remainder of this talk. I should use this as a moment to also do a pronoun disclosure. The majority of data are from the study on intimate partner violence, or from the study of heterosexual relationships with men as perpetrators and women as victims or survivors, which isn't to say that there isn't evidence among minorities, sexual minorities with men as victims, or non-intimate partners like people's parents as perpetrators. But given that the information that we have available and what is most commonly encountered in the clinical setting, the pronouns that you'll see for the remainder of the presentation really follow this kind of heteronormative relationship with men as perpetrators and women as survivors. But I think there are growing data to kind of give some nuance and sense of complexity around these issues. So in terms of a definition of intimate partner violence, it's also been known as domestic violence, or it kind of in the 70s was more known as battering. We have from the American College of Obstetricians and Gynecologists this definition: the physical injury, sexual assault, stalking, or psychological abuse by a current partner, former partner, or someone who's trying to be a partner for the purpose of asserting power and control. So this is from our practice bulletin and is supported by uniform definitions for intimate partner violence, which again, these kind of uniform definitions are really important for generating high quality data collection and surveillance. Again, revisiting and reasserting this process of legitimizing public health violence as a public health issue requiring scientific study. So digging in a little bit more to intimate partner violence, I would argue that it's preventable, as kind of shown by this public health perspective we just went over, and that it's epidemic, which I'll show in the next couple of slides. But I think a kind of moment of pause for a second to say my kind of argument that intimate partner violence serves really as a quality indicator for health by reflecting the basic safety and wellness for a subset of the population. So gender-based violence is unique in that it affects such a large percentage of those who identify as women in every aspect of their life. It frequently involves sexual offenses and is primarily committed by a known perpetrator. So examples of this include figures that time and again demonstrate that most homicides of women are committed by an intimate partner, or that there's no place where women are safe from these threats, including that the leading cause of a fatal occupational injury for women is homicide. It also is, I think, manifest in ways that school is not a safe place. And so here we have this example of Lauren McCluskey at the University of Utah, who was, this is actually very unfortunately a different headline for a different resident provider here at the University of Utah, but Lauren McCluskey was a very publicized I'm so sorry, I have a dog moving in the background, was a publicized homicide that occurred here in Utah shortly before I moved here. And even though there are these few, I think, highly publicized events, we are routinely blinded to the prevalence and dynamics of violence against women. And I think this here I chose was the case of Sarah Hawley, a resident physician here. This is a really typical headline in that it shows that friends and family were shocked and crushed. They didn't kind of know anything about what was going on, and that nowhere in this headline does it allude to the fact that this was an intimate partner violence related death. And so that's, I think, one of the examples that despite kind of these major headlines, we still don't see this as a major part of the lived experience of many folks. But I think there have been more recent efforts, most notably with the Me Too movement here, that have allowed the burden of the lived experiences of women to come to our collective consciousness. So this movement was started by civil rights activist Tarana Brooks, who's shown in the picture here, back in 2007, but was popularized by social media in the past 3 years. And data from Facebook actually show that 50% of users have at least one friend who has posted Me Too since October 2017. So I think these anecdotal data from our own personal experiences is now kind of increasingly visible, not only through Twitter or Facebook posts, but also through quality research. So this is data from the University of California, San Diego Center on Gender Equity in Health. Where they conducted a national survey of men and women, which demonstrated that 81% of women report experiencing sexual harassment or assault. So I think in this sense, we can begin to understand that violence affects us all, but those who identify as women are affected in a very particular way. And I think the intimacy and gender-based nature of these offenses may be impossible to separate from worldview, from notions of justice, from health and health-seeking behaviors, or core sense of identity. So again, I hope that this highlights the centrality of this topic to the work that we do as healthcare providers. So returning to intimate partner violence, I want to share some figures on its prevalence. This is from the National Intimate Partner and Sexual Violence Survey, which we now know was started in 2010. And it shows that over 1 in 3 women experience intimate partner violence during their lifetime using a standardized definition, and that 1 in 4 women report significant intimate partner violence related impact. So that means an injury requiring presentation to the hospital, or a diagnosis of PTSD. We know that the women, or the folks who are represented in these figures, come from diverse socioeconomic, racial and ethnic backgrounds. And in this sense, I think IPV is non-discriminating, but there are risk factors. And I think that's primarily that among some populations that are already vulnerable have higher risk of IPV victimization. And this includes folks with disabilities, people who have been trafficked, sexual, gender, racial, or ethnic minorities. And I think this intersectionality of oppressions warrants recognition. Taking a peek at IPV burden, it has enormous individual and societal costs. So there's an estimated $3.6 trillion lifetime economic cost of intimate partner violence to the United States population, most of which is accounted for in medical costs and lost productivity, and only 2% of which is attributed to criminal justice costs. This is from a New England Journal review article by Dr. Miller, who we'll talk about a little bit later on, from last year. And here it shows the wide-ranging medical comorbidities that are thought to be mediated by acute and chronic stress, activation of the neuroendocrine system and immune system, acceleration of telomere shortening, and development of coping strategies such as substance use. And there are distinct reproductive health impacts as well that we'll get to a little bit later on. So in rounding up this overview of intimate partner violence, it's important, I think, to touch upon why, as a society, we think this phenomenon happens. So earlier theories included the psychopathology of the perpetrator, so that there's some specific pathologic diagnosis of the person who is engaging in intimate partner violence behaviors. But studies show that few perpetrators have a clinically identifiable disorder, and a pathologic diagnosis would then have to extend to a large portion of the population. And this doesn't really explain why violence would be limited primarily to an intimate partner or to family members. And it's criticized for removing culpability from the perpetrator's decision to be abusive, as well as the removing culpability, I think, from the impact of environmental and cultural norms and socialization and reinforcement of gender roles, which we now recognize as contributors to intimate partner violence. So then there was a social learning theory, and it was thought that if you're exposed to violence as a child, you'll grow up to be a victim, survivor, or a perpetrator. But data show that the minority of men who grow up with violence become perpetrators. So the modern impact of this theory is really that the childhood environment is one source of influence and information about social norms, which leads us to the contemporary theory of the Duluth model. So this was born out of kind of Duluth, Minnesota, and the battered women's movement, which is a movement born out of the women's liberation movement of the 1970s. And this was really at a time when the social and political momentum grew to recognize the ethical and legal obligations to survivors of intimate partner violence. So this is around the same time that the first intimate partner violence shelters and state coalitions formed. 1975 was when married women had the legal precedent to bring criminal action against her physically violent husband for the first time. And in Duluth, Minnesota, several hundred survivors of intimate partner violence were interviewed in 1980 in this qualitative analysis. Emergence of common tactics used by perpetrators to assert what became understood as power and control within a larger context of social, economic, and other structures that inform intimate partner relationships and gender roles. So these tactics were then compiled and illustrated here in the power and control wheel. So this is a pattern of behaviors with the calculated goal of asserting power and control and achieving partner submissiveness. And how it was explained to me when I went to visit them in Duluth here was that a partner will kind of engage in these 8 central tactics, and when and if these fail to assert the submissiveness that they're interested in, then there's utilization of this outer rim of physical and sexual violence. And what I would argue is that an additional tactic deserves a wedge here, and that's reproductive coercion. Well, it does overlap with some of the other things here, like male privilege or coercion or threats and intimidation. I think there's utility in explicitly naming reproductive coercion, which helps give voice to those affected and allows us to understand as providers what has previously been a largely overlooked aspect of intimate partner violence. All right, so we're going to dig into reproductive coercion. So as I'm arguing, this is a form of intimate partner violence. It really was recently recognized by the medical community with terminology and kind of formal study starting in 2010 with Dr. Elizabeth Miller. ACOG has a practice bulletin that came out in 2013, and in that they define reproductive coercion as behavior that undermines autonomous decision-making in areas of reproductive health to maintain power and control. And these behaviors often interfere with contraceptive use and with pregnancy plans, and are categorized or have historically been categorized into birth control sabotage and pregnancy pressure, which I'm going to show examples of. So birth control sabotage includes destruction of contraceptive methods, like pulling out an IUD, pulling out a vaginal ring, flushing birth control pills down the toilet, pretending to wear a condom, but not actually wearing a condom, preventing access to a family planning clinic through threats or coercion, not withdrawing when agreed upon, other things shown here on this slide. And it also kind of the other facet, as we said, was pregnancy pressure, which includes threats to coerce conception or continuing a pregnancy, or kind of as the flip side, threats or violence to end a pregnancy. And data have shown both pro-pregnancy and pro-termination tactics, but the former has definitely been reported much more commonly. So in terms of how a lot of the data around reproductive coercion has been generated, the reproductive coercion scale is a 10-item instrument that was developed by Dr. Elizabeth Miller back in 2010, based on her experience as an adolescent medicine clinician, and from a qualitative study she conducted in 2007. And this scale has been used in the majority of research produced on reproductive coercion, which has been really important to provide this standardization to a new field and has really enormously shaped what we know. And so she kindly shared this with me in years past, and it includes the following. In the past 3 months, as someone you were dating or going out with tried to force or pressure you to become pregnant, told you not to use any birth control, said he would leave you if you didn't get pregnant, told you he would have a baby with someone else if you didn't get pregnant, taken off the condom while you were having sex, put holes in the condom, broken the condom, taken your birth control away from you or kept you from going to the clinic, made you have sex without a condom, hurt you physically because you did not agree to get pregnant. So again, this is really, and we'll kind of see in the data that we're about to go through, has shaped what we know, and has been enormously helpful. But I think also kind of the future of reproductive coercion research will involve some modification here to incorporate what we now know about reproductive coercion, which includes more tactics than this, and perhaps will also involve elimination of this intent. I mean, my approach would be to borrow data from and kind of the framework that we have around intimate partner violence to inform a screening instrument. And in intimate partner violence, we don't include intentionality. So we might be able to identify even more folks. And I think that kind of in the numbers and figures that are to follow, that we probably are just beginning to measure the impact of reproductive coercion in the and its impact on reproductive and sexual health in our patients' lives. So this is from one of her studies in terms of the tactics that come up most commonly. So this is just from the past 3 months of 3,500 English and Spanish speaking women aged 16 to 29 who presented to a number of clinics in Pennsylvania. And here you can see that the most common tactics that were reported was the condom being taken off during sex, being told not to use contraception, and threats to pressure pregnancy. I think we can take a closer look at one of these tactics to, again, I think, reiterate my kind of central thesis here, which would be the importance of using an IPV lens in understanding reproductive coercion, and that is stealthing. It's also known as non-consensual condom removal. And you may have heard of this tactic because it's been in the headlines pretty frequently in the past couple years. And I think it's a great example of how tactics are better understood not through intention to cause pregnancy, but rather through a function of asserting power and control. Starting with the term stealthing is thought to have originated in the men who have sex with men community to describe practices of non-consensual condom removal by HIV positive men who reported an intention to spread STIs to their partners. So obviously reproductive kind of outcomes are different in that population. And the familiarity with stealthing was further gained kind of further recognition in 2017 by Alexander Brodsky, who was a Columbia Law Fellow at the time, who published an article describing non-consensual condom removal as quote unquote rape adjacent. And she describes in detail survivors who report their concerns for pregnancy and STIs after discovering that condoms had been removed without their consent, and also what felt to them like a unrecognized, labelless form of violence. In that analysis, which is super interesting, I would totally recommend reading. Brodsky also reviews online forums with accounts and advice for how to carry out stealthing by men who are perpetrating this kind of phenomenon, which they articulate in these forums reinforcement of gender norms and power dynamics as the motivation for these behaviors. So I think it highlights two important things. One is that sexual violence is not about force, but is rather about consent, and that reproductive coercion is less about pregnancy and more about power and control. So before moving on from a description of tactics, I wanted to review some qualitative data, which is informative, I think, of the dynamics at work here and centers the voices of those who are affected. So the impact, I think, of reproductive coercion is not just at the time of sexual activity, but through expectations established beforehand. And so some of the quotations here are about contraceptive negotiation silencing. And these are from small focus groups where study participants described asking for protected intercourse with condoms, bringing into question their fidelity or commitment and this kind of idea of mistrust of their partners, and that they were saying that willingness to engage in sexual activities without condoms reflected their commitment to a monogamous relationship, whereas condom requests would be equated with having other sexual partners or doubting their current partner's investment in the relationship. So you can see that in these quotations here. And here in this quotation, this is through a report from a friend who the friend was affected by reproductive coercion, I think does a good job of showing the intensity of some of these threats and the way that the reproductive coercion is interrupting schooling and independence. And also that this person kind of developed other relationships regardless of this pregnancy being continued. And I think it decentralizes the importance of pregnancy itself, but rather the control attained. And I think this does a good job. This last quotation, or second to last quotation here, shows the forces at work after conception. So refusing some of the things that we've seen in qualitative data are refusing to help pay for an abortion, making a partner eat before a procedure, One study participant described destructive behaviors at a clinic. So both she and her partner were asked to leave before receiving family planning services. In this example, withholding transportation, or a partner stating that he will not pay for child support if a pregnancy continues. I think this is particularly interesting in terms of subsequent reproductive outcomes for this participant. And then this final example here, I think, again, shows the range of behaviors and also shows an example of what I'll call a resistance strategy that we'll revisit a little bit later on. But this participant ended up hiding her birth control pills in an effort to retain some reproductive autonomy. Okay, so next I want to go through the prevalence of reproductive coercion and some of the kind of epidemiology of reproductive coercion. Prevalence varies significantly based on the setting. So I think probably what's important to this audience is this is a study by Clark from a investigation set in general OB/GYN outpatient offices of 600 individuals who just presented for routine care, and 16% of those who participated in the study reported prior reproductive coercion. But this varies significantly. In a CDC 2-item questionnaire in a national population, about 10% reported prior reproductive coercion, although I would think that there's underrepresentation there given the limited number of questions that were utilized. And then this is from a study by Moore set in a domestic violence shelter, where there were much higher figures among folks who are reporting other forms of and other tactics of intimate partner violence are reporting very high rates of reproductive coercion. In terms of what we have available for risk factors for reproductive coercion, there's really been mixed data yielded from investigation of demographics. So some studies have shown increased risk among racial and ethnic minorities, among folks with less formal education, some mixed associations with relationship status. But I think it's hard to draw a conclusion other than existing inequalities likely also increase risk for IPV and RC. But the reality for a clinician is that that risk is universal in thinking about the patients that we're serving. There is, though, a very robust association with other IPV tactics. So the takeaway for that is that in identifying someone affected by reproductive coercion, we are identifying an individual who's at significantly higher risk for other forms of physical, sexual, or emotional violence. So transitioning into the health implications of reproductive coercion, well, there are growing data in this new field. Several significant relationships have emerged in health-seeking behaviors and reproductive health outcomes of those affected by reproductive coercion. In the following slides, we'll have some specifics on the increased utilization of tests, increased emergency contraception use, rates of unintended pregnancy, and decreased utilization of contraception. But the point being here in terms of kind of overarching takeaway that the impact of reproductive coercion is likely much more far-reaching, as has been demonstrated by intimate partner violence and introduced at the start of this talk, but is beyond the scope of the kind of remainder of our discussion today and has yet, I think, to formally be studied. So looking at testing specifically, these are data from a study of 1,300 English and Spanish speaking folks at 5 different clinics who were asked about behaviors during the prior 3 months. And among kind of STI testing, those who reported reproductive coercion were a little more than 2.5 times as likely to get more than 2 STI tests in the preceding months. And similarly with pregnancy testing, those who were reporting reproductive coercion were much more likely to have sought one or more pregnancy tests in the last couple months, and that relationship was stronger with an increasing number of pregnancy tests that were requested. And this is not to pathologize these behaviors of asking for STI testing or pregnancy testing, but rather to demonstrate to clinicians who might benefit from additional questions or support, and to develop compassion for what may look like overutilization of healthcare, when in reality, I would say that to me, these are resistance strategies. Looking at contraceptive use, so I think that the data available really demonstrate that these tactics of reproductive coercion are effective. Not only do partners make it difficult to utilize contraception, but data show that affected individuals are less likely to use contraception in reality. So these are data from sexually active college-age women, that show that they were less likely to use contraception at time of last vaginal intercourse. And then there was a similar study that was conducted at a domestic violence shelter that supported the same findings of decreased utilization of contraception at time of last sex. And to provide further nuance to that, the study that was by Katz that was done at a college showed that those who were affected by reproductive coercion were more likely to report decreased sense of contraceptive and sexual self-efficacy, which they defined as the ability to take control of or feel responsibility for sexual activity. In terms of emergency contraception, those who were reported reproductive coercion were over 2.5 times as likely to use EC in the last couple months. And then logically, this was from a study of 150 sexually active teenagers in an academic hospital satellite clinic. And they were 3 times as they had a 3 times increased risk of past or current chlamydia infection if they reported reproductive coercion. In terms of unintended pregnancy, so in these studies, unintended pregnancy was defined broadly as a pregnancy that was not planned, was unexpected, was mistimed, or was not wanted by the participant. And this is from, these data are from 3,700 individuals in clinics around Pennsylvania. Of all comers who presented to these outpatient clinics, 12% reported unintended pregnancy in the last year. Here. Those who reported reproductive coercion, 21% reported unintended pregnancy. And then those who reported intimate partner violence had a 16% kind of report of unintended pregnancy in the last year. And so while I've been arguing that reproductive coercion is a tactic of intimate partner violence, many studies have separated intimate partner violence out. And what I think is interesting here is that we know intimate partner violence is associated with unintended pregnancy, and perhaps reproductive coercion is a large part of that association. The figures I just gave you and kind of that are shown here actually are from this Miller study of 3,700 folks. This was also replicated with almost the exact same numbers from a survey done among college women. So I imagine that a lot of folks listening today provide perinatal care. So I wanted to address that specifically, but unfortunately we would have to extrapolate a lot from intimate partner violence data, which demonstrates the effect throughout the course of pregnancy and beyond. So we know here at the time of conception, there's increased undesired pregnancy. So this is from a study I did in residency, where those who reported reproductive coercion at the time of last birth, 30% said that they never wanted to be pregnant again at the time of conception. We also know that there's increased presentation, and this is for folks affected by IPV, increased presentation for abortion, and that really highlights the importance of comprehensive reproductive care for this population. in prenatal care. We have data from national surveys that shows large, substantial number of women. So these are studies with 200,000 women in them that have shown increased risk of inadequate prenatal care, uh, which is kind of deemed as fewer than 4 visits. Increased likelihood to have inadequate nutrition. Data from Canada show that intimate partner violence increases the risk of a diagnosis of depression during pregnancy, increased risk of smoking, increased risk of alcohol intake, and increased risk of drug use. Homicide is the leading cause of death among pregnant women. Most homicides are committed by intimate partners. So I actually looked for Utah data on this, and of all the homicides of women in 2019, 8 of the 12 were by intimate partner violence, further substantiating that, again, homicides of women are primarily committed by intimate partners. In terms of birth outcomes, there are really large meta-analyses of intimate partner violence and risk of poor birth outcomes, including preterm birth and low birth weight. And then again, from the study that I did in residency, it also substantiated that separating out reproductive coercion, there's increased risk of low birth weight among those who report RC at the time of their last pregnancy. And then I think childhood exposure has numerous downstream effects that are beyond the scope of this talk, but these are data out of a University of Michigan study that followed women who were affected by intimate partner violence during their pregnancy and their children over time. Okay, so transitioning to our role as healthcare providers in providing support, I think we have to put this kind of our family planning in context here when we're thinking about reproductive coercion in our patient population. So I think our practice is really to focus on the individual in front of us, but in caring for a person affected by reproductive coercion requires accounting for her environment and what we do often, but that recognizing that her reproductive outcomes, her health-seeking behaviors, medication or testing use, as we've shown, may be dictated by the actions of her partner. So really expanding kind of our bubble in terms of who we're addressing or thinking about. And that what I would argue is that contraceptive counseling, reproductive and sexual health at large is really, that care and counseling is really incomplete without the knowledge of presence of reproductive coercion. So the slides that we're about to look at will review how we can integrate these considerations. But first, in terms of kind of the rationale, to reiterate that I think the data that presented so far have demonstrated that there are grave health consequences from reproductive coercion and intimate partner violence, that reproductive coercion really represents gross infringement on autonomy, and that there are a significant number of affected individuals, which to me signals a call to action for this phenomenon. And I think distinguishing RC is distinguished from IPV in that the clinical setting is not only the site of identification, but it's also the site of intervention, which is really unlike a lot of what we think of for violence and making warm referrals to community organizations. The work that we're doing around RC is consistent with work that we do all the time, including pregnancy testing, STI testing, contraceptive counseling, or pregnancy management counseling. Let me look at the time right now. I actually can't see the time. How are we doing on time? Did I just close my slide? I'm so sorry. Okay, can we see okay still? I think so. Okay, speeding along so that we have time for questions. So as primary care providers, we're routinely screening for intimate partner violence, and this practice should expand to include specific evaluation for reproductive coercion. Beyond universal annual screening, we'll review particular scenarios for additional screening shortly. And you guys will get an email that includes a really nice document for healthcare providers from Futures Without Violence to help give you some more language in case we can't cover a ton this evening. But big point here is that um, screening also serves as a method of education. And in turn, that is a method of prevention. So cultural notions of assault perpetuate ideas that violence by an intimate partner or an acquaintance is not as legitimate as attacks by a stranger. And furthermore, reproductive coercion can be confusing because it may occur in a scenario where a person consents to sexual activity with a condom. So, whereas legally or culturally it may not be possible, medically we can distinguish and help patients distinguish that consent to sex and consent to their partner's. Their sexual partner's coercive or deceptive practices and their consequences, including the socioeconomic and medical implications of pregnancy or STIs, is not okay. So, screening, even without disclosure, is an opportunity to communicate the moral wrongs of IPV and RC and their medical harms. In thinking about screening, it's always important to disclose mandated reporter status. In Utah, as in most states, medical personnel have to report child abuse and elder abuse or treatment of injury with a deadly weapon. So disclosure of our status really helps preserve trust and allows persons most familiar with an abuser and his triggers to determine what information should be passed along to police. And then if you do find yourself in a situation where a report needs to be made, to invite the patient to listen in and ask if there are specific details that she would like to have included. In terms of screening, assessing for reproductive coercion in the research setting has used that reproductive coercion scale that we went over, but that has not been validated or really utilized in a clinical setting. So this is language from the American College of Obstetrician Gynecologist Practice Bulletin, which I think is all totally reasonable. And you can look at through that practice bulletin that we're happy to share if folks want that. But there also is going to be some more specific language in the following slides here. So thinking of kind of specific times to think about and ask about reproductive coercion, I think really includes making sure we're having nuanced contraceptive counseling. So before providing a ton of time on contraceptive counseling, patients should be screened and make sure that what we're kind of our recommendations are in line with what would be appropriate for their lives. Some of the things that in the Futures Without Violence PDF you guys can get, they use, let me see what I'm doing. They use language that includes, does your partner mess with your birth control? Does your partner refuse to use condoms? Does your partner make you have sex when you don't want to? Or if you've already screened someone for intimate partner violence and they screen positive, that should then trigger a talk about contraceptive options that are less susceptible to be tampered with, which we'll talk about more in a second. If someone's comes to you to ask about barrier methods, you can use that moment to ask if she's comfortable asking her partner to use condoms, if her partner is supportive of utilization of condoms. If someone's coming to you for an emergency contraceptive visit or calls in asking for emergency contraception, that's an important opportunity to ask about consensual sexual activity or reproductive coercion. Words that you can use for that include, was sex something you wanted to do? Are you concerned that your partner may be trying to get you pregnant, or that your partner may be messing with your birth control or may mess with these emergency contraception pills? When someone comes in for STI testing, that's an opportunity to ask about comfort with barrier methods and partners' acceptance of barrier methods. And if there is a positive result, I think a good thing for us to think of in terms of supporting our patients is that some partners can oftentimes controlling partners have multiple sex partners or make it difficult for their partner to use condoms. And we can introduce that concept to our patients. And sometimes these partners also make our patients feel unsafe talking about STI prevention or test results. So we'll talk about kind of ways that we can help deliver test results in the following slides. Pregnancy tests or establishing prenatal care. So some of the things that you can say is, because this happens to many women, we ask all of our patients who come in for a pregnancy test if they're able to make decisions about pregnancy and birth control without threats or interference. by their partner? How are these decisions made in your relationship? Or at the start of a prenatal care visit, I think most providers routinely ask if the pregnancy was planned and desired, and I think this is a really important moment to probe deeper. If it's unplanned, ask if using contraception, if she was using contraception and wanted to be using contraception. In my clinical career, this is how almost all of my patients who were affected by reproductive coercion were identified, was when they came to establish prenatal care with me, before I started more routinely screening for RC. And if there is a disclosure of reproductive coercion, I think it's important to ask more broadly about intimate partner violence. I think that's everything on that slide. So I am so sorry that I can't see the time unless I sneak out there. I'm going to go pretty quickly through the next little part here, including just mentioning that what we know about harm reduction is informed by resistance strategies that women have shared with us in qualitative studies. And that includes things like disguising their contraception, setting expectations long before sexual activity, asking their providers for LARC or Depo, Provera. And these women have then informed kind of what we can utilize or employ as care providers. So after the slide, I'm going to pause and see if there are questions before people have to go, but this is kind of the big bulk takeaway in terms of what we can do for our practices. So in terms of contraceptive counseling, we can ask if more discrete options make sense for that patient, things that don't require regular intervention and are less susceptible to tampering. So instead of using a pill, patch, or ring that could be destroyed, does using Depo, an IUD, or an Nexplanon make more sense? You can offer to increase discretion by trimming IUD strings into the cervical canal, with knowledge that they may require a little more finagling to get out, or referral to a family planning specialist to remove the IUD. And you can ask if a partner monitors menses, and if so, it may be better to use a copper IUD or to continue discrete use of pills. You can give emergency contraception. We should make it as easy as possible for folks to have access to emergency contraception, and provide education on its use, and take it out of the packaging if it's being given in the office, or encourage them to store it in a different container at home if they're picking it up at a pharmacy. In terms of pregnancy management, we can offer, so again, offering urine pregnancy tests, offering emergency contraception, and using kind of health-seeking behaviors in that regard to ask more about reproductive coercion. But if someone's coming to seek abortion care in the setting of reproductive coercion, to ask if it makes more sense to have a medical abortion if they're within the gestational age limit, because that can be disguised as a miscarriage, or if surgical abortion makes sense because she has already come and made the effort to be at the clinic, and she can be kind of taken care of in one setting, rather than to take pill mifepristone and then have the opportunity for misoprostol to be tampered with at home. If folks want to continue prenatal care, then you can talk about postpartum contraception opportunities. So if it makes sense to initiate methods within the hospital, so to get a Depo shot in postpartum while hospitalized, or a post-placental IUD. In screening for STIs, we can discuss the kind of optimal frequency of testing. So anyone without a monogamous partner warrants screening at the time of presentation to care. You can help with informing the partner of positive results. So you can ask if she would like to inform her partner herself if there's a positive STI screen, or would like an anonymous call from your office. There have been, let me skip that actually. Let me just say that the kind of guidelines, the current CDC guidelines highlight consideration of PrEP for anyone who is at significant risk of HIV, which includes inconsistent condom use, a violent partner, non-monogamous partner, which obviously is overlapping with folks affected by reproductive coercion. And then in terms of referral, with screening should have a meaningful intervention, which includes these parts of routine obstetrical and gynecologic care here, but also can involve referral to an advocate. And so I'll show you some local resources in a second. But the office can be a really important place to make phone calls or to use private space without fear that a partner is monitoring that phone call or text messages or websites visited. So as you can see, big takeaway here, these things are all things that are routinely done or discussed at least in a primary care office. So you already have the power to intervene for reproductive coercion. Given what looks like time limits, why don't I pause and just see if anyone has questions? Basically, what remains is just a little bit about local Utah resources and kind of future research. But I want to make sure that we have time to chat before folks have to go. Questions that have come up. Otherwise, I can just keep on speeding through.
Thanks, Kathryn. One point I want to highlight, especially for those folks who are tuning in from our FBE contraceptive access program sites, and just to reiterate that we don't have any per client restriction on prescription methods that can be dispensed. So we actually don't track per client usage. So if you have a client who's reported destroyed contraceptives, then don't hesitate to redispense those.
That's a great point.
From a programmatic perspective. And then we do have a couple questions here. Let's see, we have, I am curious about the relationship between reproductive coercion and what I imagine would be decreased sexual pleasure in current and perhaps future relationships. Is there anything in the literature about this?
That's such a great question. And to my knowledge, there hasn't been anything that has focused on specifically reproductive coercion. So again, we would have to extrapolate from intimate partner violence, and a major correlation in terms of folks who report prior or current IPV is chronic pelvic pain, and certainly decreased sexual pleasure. So I'm confident that if there were a study for RC, it would show something similar.
Okay. Another question, how common do you think it is that reproductive coercion occurs and the person experiencing it believes it is a normal relationships behavior? And then to piggyback on that, a question that I have is, has there been any trend in popular media as far as books and films and TV in defining this type of behavior as reproductive coercion or intimate partner violence?
Yeah, so the first part, for sure. So I think that a lot of the qualitative study and some of those quotations we had from survivors, I think shows that willingness to engage in intercourse without a condom, if that's what was wanted, is a demonstration of fidelity. And so there's kind of this mixing of relationship values with what I would call reproductive coercion. And so it can be problematic that if in order to demonstrate fidelity or investment in a relationship, you don't get to use the method you want, I think is kind of where there's that conflation of values. Other examples, I think in general, just in terms of like gender norms and kind of problematic societal normalization of relationship behaviors, includes this idea of jealousy being kind of, again, reflective of investment in a relationship to an extent that can be problematic. And that's why I think screening is so important, because it also serves as a form of education. My kind of interest would be in the future, in a somewhat related note, if there would be some way to also think of identifying reproductive coercion and some of these tactics that are a little bit harder to flesh out to elicit kind of, does this behavior cause you distress? So if there's something like someone in a monogamous relationship and their partner doesn't want to use a condom and they feel pretty kind of neutral about it. I'm not sure that that person requires a ton of intervention or support. However, if it's very distressing to the person in front of us that they can't use a contraceptive method of their choice, then that would be someone who we'd want to identify. So right now that scale doesn't involve some sort of metric of whether or not these behaviors are causing distress, but I think both through screening and education, we can help inform the parameters of a healthy relationship and what reproductive coercion is, but also as providers, we can make sure we're not pathologizing relationships in ways that don't necessarily need to be.
Thank you. We do have one more question. How do you screen for RC at a prenatal visit without making the client feel embarrassed that they got pregnant when they didn't intend to?
I think that however folks are asking, so I always ask if someone's coming in and the pregnancy is something that was planned or desired. And I think that that is an invitation for someone to say, if it wasn't planned or wasn't desired, to then explore a little bit more what they want to do with that pregnancy. I think oftentimes you'll see on your clinic schedule first prenatal care visit, and the most important thing would be to go into that visit universally, fleshing out the emotions that someone's bringing to that first visit rather than a congratulations and initiation of prenatal care, because there have been countless times when me or my colleagues have had that first prenatal care visit when in reality it ended up being a referral to abortion care visit.
Gotcha. Okay. And one question from Suzanne, one of our loyal participants. She says, this was great. I'm curious what's known about what's in the power for perpetrators. Are there indicators for those more likely to perpetrate? Heard what you said about psychopathology versus social learning, but curious about income, age, concurrent stress, sports involvement.
I'm trying to think if I've seen, I think maybe there's one researcher, Tamara Collins, who has done like a dyadic approach to reproductive coercion, and she might have a little bit more information about kind of perpetrators and kind of demographics or associations of perpetrators and reproductive coercion. I'm not super familiar with a lot of work there, and I think probably there just hasn't been a lot generated. The same was the case. So I kind of, before I went to medical school, I was a domestic violence advocate, and there were batterers intervention programs and data that came out of that. And there's one amazing researcher who I'm hoping will come to, I will remember and then have it sent to you, who has done a really interesting work around who's likely to be an intimate partner violence perpetrator, particularly in college settings, that I think to me was very illuminating. And I assume that a lot of that work could be extrapolated for reproductive coercion. But again, this is such a nascent field that I can't say that there's a lot that I can point to for RT specific risk factors for perpetration. I also think that there's probably a lot of cultural nuance in how relationships are defined and kind of what normal dynamics of a relationship would be. And that's not to use that as an excuse for problematic behavior, but definitely in terms of like parental involvement in reproductive outcomes, and kind of acceptability or kind of planning around pregnancies can be conceived of very differently by different kind of cultural backgrounds that I think complicates weeding out those risk factors, if that makes sense.
Right. Yes. Thank you so much. And that's all the questions we have. If folks are able to stick around, it'd be great to look at local resources. If not, we will also paste that post survey link in the chat. There it is. If you wouldn't mind filling that out for us before you head out.
Perfect. Is it okay if then I just do like 5 more minutes here?
That would be wonderful. Thank you, Kathryn.
Okay. Can you still see my screen? It's
We
like
can,
8 months into Zoom life and I still am struggling here.
we can see it and you can go ahead and put in, yep, that's great.
Perfect. Okay, so we had talked about, we talked about these things. Okay, so in terms of local resources, a big takeaway is that every state has a coalition for domestic violence and sexual violence. Sometimes that's the same organization in the same place. And for some states, they have a DV or an SV organization. So this is kind of Utah's information here. And then there are a bunch of other more local resources, like in Salt Lake City, we have the YWCA, which is great. And then we also, I just loved this map. This is from Utah's Sexual Violence Coalition. They put through a bunch of different resources throughout the state, including different supportive agencies and police stations that have victim advocates, which is great. So I know that every state, again, has a dedicated coalition, as we know now, born out of the 1970s, 1980s liberation movement. And report building, I think just because, like, for 2 seconds on this, there's not a lot of formalized training around the language that we use, and it can, I think, be hard and uncomfortable to talk about violence. So in terms of general principles, working on paraphrasing, talk before touch is a huge part of what we're doing as reproductive and sexual health care providers, using open-ended questions and reflecting the language that the person in front of you is using. Things that can sometimes slip out and seem potentially like they would be compassionate but can be misconstrued include things like, I know exactly how you feel, or it is going to be okay. Frankly, sometimes it's not going to be okay. Talking about your own experiences of abuse, or why did you do that? Are you letting him do blah, blah, blah? These are examples of things where I think the curious and well-intentioned provider can kind of limit the rapport that's developed with the person in front of you. Another way that we think about language that I quickly want to address, because this can be an area that I think burns out potentially very supportive providers, is the why does she stay question. And particularly if we're following someone over time and we're seeing this person navigate situations that frankly can be scary. So this is a shortened list put forward by Campbell that I collected from my time kind of as a DV advocate, that I think is really illustrative. And I think hammers home that, one, that we know that the individuals in these situations are the most familiar with how to navigate danger. And so the Department of Justice has demonstrated that by most conservative estimate that there's a 4 to 5 times increased risk of femicide following attempt to leave a partner in the setting of intimate partner violence. So the core principle that we always return to is that the survivor is the expert of her life. And that also informs those clinical interventions that we talked about in the preceding slides. Evidence for intervention very quickly. So there are data that show that patients want their healthcare providers to talk about discrete methods of contraception in the setting of reproductive coercion. That there's preliminary data that show that screening and education around reproductive coercion helps decrease risk of reproductive coercion and increases the likelihood that relationships with reproductive coercion are ended. And that providers who have training on screening and are given tools to assist folks affected by reproductive coercion end up feeling quite comfortable in responding to this issue. Future research briefly, I think that we are in the process of developing some improved screening methods that we can have more clarity. We right now just have a nascent idea of the impact on health that reproductive coercion has. I'm sure it's much bigger than what we can imagine with the data from the slideshow. And that, as always, we need more effective primary and secondary prevention measures beyond the education that we can provide at this time, and then the kind of nuanced routine care that we are already providing, taking into consideration the things that we can do to restore autonomy for folks affected by reproductive coercion. Big conclusions: violence is a fundamental part of the providing quality care. Reproductive coercion is prevalent and has a profound impact on health, and that the OB/GYN office is a critical spot for us to identify and to intervene with interventions that are already very routine and familiar to us. Questions, any second set of questions at this point? Chat, where's my chat? So the things that I should give you guys is the a couple PDFs. I think the Futures Without Violence PDF will be the one that helps consolidate a lot of the information in this slideshow into clinically useful language. And if there's any other questions or concerns come up, let me know. Awesome.
Wonderful. Thank you so much, Kathryn.